Good afternoon, everyone. My name is Dr. Goutami, one of the consultant neonatologist and pediatrician at KIMS Cuddles, Kondapur. Today, I'm going to discuss about one of the important condition while managing the preterm babies in the NICU, that is metabolic bone disease, formerly known as osteopenia of prematurity. Metabolic bone disease, also known as osteopenia of prematurity. As we are managing more number of preterm babies with extreme low birth weight and very low birth weight babies, the incidence of osteopenia of prematurity is also increasing. So today I'll discuss about the calcium and phosphorus homeostasis during the fetal life and immediately after the postnatal transition and what happens in the extreme preterm babies and very preterm babies. So we'll have a clear-cut idea how to diagnose it and how to manage the metabolic bone disease. Metabolic bone disease is defined as a reduction in the bone mineral content related to the expected level of mineralization for an infant of comparable size or gestational age in combination with the radiographic and biochemical changes. It is also referred to as osteopenia or rickets of prematurity. We'll discuss about few terminologies used, such as osteopenia is nothing but diminished bone mineral density secondary to the reduction in the thickness of the bone cortex and trabecula. In this, there will be reduction in the bone cortex and trabecula. In that, mineral density is also been diminished. Osteoporosis is defined in pediatrics as a reduction in the bone mineral density with clinically significant fractures, whereas rickets means undermineralization of the bone matrix or osteoid in the growing bone. It involves both the growth plate, that is physis, and newly formed trabecular and cortical bone. Whereas osteomalacia is also a type of ricket, but it occurs in the absence of linear growth after the completion of the growth spurt. Incidence in very low birth weight babies, the incidence is 25%, and in extreme low birth weight babies, the incidence of metabolic bone disease is around 50%. Average, it is 16 to 40% incidence is there in preterm babies. It is chiefly caused by the deficiency of dietary phosphate and calcium levels. In the fetal life, 80% of the bone mineralization occurs during the third trimester of pregnancy. So first, we will see what happens in fetal life. Placenta is the main site of transfer of calcium and phosphate in fetuses through the active transport, and fetal accretion rate is around 60 to 60 milligram per day at 24 weeks of gestation age, which has been increased and it peaks around 34 weeks, that is 300 to 350 milligrams per day. So we will see what are the hormones plays the roles in calcium and phosphorus and vitamin D metabolism in the fetus. So placenta transports calcium, phosphate, and magnesium from the maternal to the fetal circulation. So there will be hypercalcemia in the baby, in the fetus. This hypercalcemia, this is whole in the baby's side. So hypercalcemia in the baby stimulates the calcium sensing receptors, and this calcium receptor will causes inactivation of the parathyroid hormone levels, that is reduction in the parathyroid hormone levels. So normally what parathyroid hormone causes, it increases the reabsorption of calcium, and it will cause the resorption of the bone. So it mobilizes the calcium in the bone and it increases the calcium level in the blood. So decreased parathyroid hormone level causes calcium and phosphate regulation, that is calcium and phosphate deposition in the bone. It will have inverse relationship with the phosphorus. That is, parathyroid hormone will causes loss of phosphate in the by the kidneys. So decreased parathyroid hormone levels cause reabsorption of the phosphate and calcium and phosphate deposition in the bone. So it indirectly helps decreased PTH helps in the bone formation. And another thing is, in fetal life, calcitonin and parathyroid hormone related peptides are relatively on the higher side. So, what is the function of calcitonin? It reabsorbs the calcium and phosphorus and it helps in bone deposition. So, increased calcitonin causes bone deposition, decreased PTH causes calcium and phosphorus deposition in the bone, and increased parathyroid hormone related peptides also causes bone formation. And decreased parathyroid hormone will decreases the 1-alpha hydroxylase. Normally, parathyroid hormone is essential for stimulating the 1-alpha hydroxylase, which causes the 1-alpha hydroxylation of the vitamin D, 25 hydroxy vitamin D3 in the kidneys, which is the active form of the vitamin D3. So decreased PTH causes decreased 1-alpha hydroxylation, leading to decreased calcitriol levels, and FGF23, that is fibroblast growth factor, and increased 24 hydroxylase. It is from the placenta. Placenta will producing 24 hydroxylase enzymes, which is also antagonist for the calcitriol. So these are the hormones responsible for the fetal accretion of calcium and phosphate in the baby. So in the fetus, there will be decreased parathyroid hormone and elevation of the parathyroid hormone related peptide. And another thing is calcitonin hormone will also be more in fetus, more in the fetus, which causes calcium and phosphorus deposition in the bones. And there will be decreased calcitriol and decreased 125 hydroxy vitamin D3, whereas increased 24-25 hydroxy vitamin D2 or increased 124-25 trihydroxy vitamin D. Okay. And another thing most important is the calcitonin and parathyroid hormone levels. They do not cross the placental barrier. So the elevated calcitonin and decreased PTH levels will causes the fetal accretion of the calcium and phosphorus in the bones. So calcitonin and parathyroid hormones, they won't cross the placenta. And this figure, all of you know, I think this is most favorite and famous algorithm for vitamin D metabolism. But for just quick reference, I kept here. So vitamin D2 from the diet or from the sunlight is converted to the active form of vitamin D3 by two hydroxylations will happen. One hydroxylation that is in the liver and another hydroxylation in the kidneys. In liver, first hydroxylation will happen with 25 hydroxylase, that is 25 hydroxy vitamin D2. Next, last activation step occurs in the kidneys, that is with the help of 1-alpha hydroxylase producing 125 hydroxy vitamin D3. This 125 hydroxy vitamin D3 increases the calcium and phosphorus reabsorption. And this in turn will inhibit the parathyroid hormone. Okay. So what happens after the delivery? After the delivery, the calcium and phosphorus influx and active transport from the placenta is stopped. So there will be decrease in the relatively decreased level of calcium will be there, and the calcium level falls in the newborn baby just after the delivery, and it reaches a nadir at 24 to 48 hours. In some babies, it will take until 72 hours. So the decreased calcium causes activation of the parathyroid hormone. This parathyroid hormone will cause resorption of the bone, releasing the calcium from the bone, and the blood levels in the calcium will be elevated. and renal reabsorption of the calcium will occur, and whereas renal excretion of the phosphate will happen, and this parathyroid hormone activates the 1-alpha hydroxylase enzyme, which converts 25 hydroxy vitamin D2 to 125 dihydroxy vitamin D3. So, by this mechanism of resorption of the bone and release of calcium from the bone to the blood levels, in mild, moderate, and in some cases severe degree of osteopenia or prematurity, also the calcium levels can be normal. So, so we should not treat the babies depending upon the calcium levels alone. So we have seen the definitions, some few terminologies, what happens in the fetal life, postnatal life. Now we will see the what are the prenatal risk factors. One is placental insufficiency. So insufficiency of the placenta causes decreased transport of calcium and phosphorus into the fetus, maternal vitamin D3 deficiency, and genetically high TA repeats and male gender. Other risk factors are prematurity. There is loss of maximal in utero mineralization, low birth weight. It is associated again with prematurity and with low birth weight, fetal growth retardation, intrauterine growth restriction associated with maternal disorders such as placental insufficiency, which will be results in reduced active placental transport of minerals in utero. Loss of maternal estrogen. It increases the osteoclast formation and bone resorption. So, estrogen is essential for osteoblastic activity. So, maternal estrogen will increases the osteoclastic activity. Reduced physical activity causes increased bone resorption from reduced mechanical stimulation and deformation. Parenteral nutrition. Again, it will have, so many reasons are there why parenteral nutrition will cause osteopenia, like limitation in the calcium phosphate content due to precipitation. Glucocorticoids reduces the gut absorption of the minerals and a direct osteoclastic activity on the bone. Antacids reduces the gut absorption of the calcium due to neutralization of stomach acid. So acidic pH is essential for calcium absorption. If the acidic pH is lost, then calcium absorption will be impaired. Loop diuretics, they will have direct effect, that is increased renal calcium loss. Chronic lung diseases, higher energy requirements will be there. In chronic lung disease, we use diuretics, glucocorticoids. In turn, they also have an additive effect. Necrotizing enterocolitis in NEC will keep the baby on NPO, will give TPN. TPN again will have its adverse effects on calcium and phosphate metabolism. And poor gut function will also lead to poor absorption of the minerals. And another thing is excessive phosphate supplementation. This is very important. We should not give phosphate or calcium alone for the treatment of osteopenia of prematurity, because excessive phosphate, I will show in the subsequent slides how it has a vicious cycle in the osteopenia of prematurity. So excessive phosphate will lead to activation of the parathyroid hormone known as secondary hyperparathyroidism. In turn, will cause bone resorption. In fact, we are doing bad for the baby by giving phosphate alone supplementation. So what are the non-nutritional risk factors for metabolic bone disease? Early withdrawal of the placental estradiol and progesterone in case of prematurity, placental insufficiency, lack of mobility, and another thing is copper deficiency. A few of the medications which are associated with OOP are glucocorticoids, furosemide, loop diuretics, methylxanthine such as caffeine, anticonvulsants such as phenytoin, phenobarbital, antacids, proton pump inhibitors, and H2 blockers. Now we'll see the pathophysiology of the calcipenic metabolic bone disease. So vitamin D or calcium deficiency when it occurs is decreases the ionized calcium levels. So decreased ionized calcium levels it will activate the parathyroid hormone secretion. So increased PTH will cause bone resorption and mobilizes the calcium and phosphorus from the bone, leading to osteopenia. And in by this mobilization, the calcium will be reabsorbed. So the calcium level can be low, normal, or decreased also, but most of the time it will be normal or slightly low. And there will be decrease. This parathyroid hormone will decreases the phosphorus, means that is it increases the urinary excretion of the phosphate by the renal tubules. So there will be loss of phosphorus and there will be increased alkaline phosphatase levels. So this decreased phosphate level, so we have seen the decreased phosphate levels in the baby blood reports, and we calcium is normal. So we have started only phosphorus supplementation for the baby. So what this phosphorus supplementation will do to the baby? If we do not give the calcium and phosphate in the optimized ratio, that is 1.7 or to 1.3:1, then there will be decreased calcium levels comparison to the phosphate levels, and it is sensed by the PTH again in the body, and it further leads to bone resorption. So by giving the phosphate supplementation, we are doing more harm for the baby. That is, we are bone resorption, we are favoring the resorption, and it is a vicious cycle. Now we'll come to the clinical presentation. Mostly the osteopenia of prematurity presents at 5 to 11 weeks of postnatal age. And it presents with poor extrauterine growth, increased work of breathing due to rib softening and fractures, leading to alterations in the lung compliance and fractures. So bone manifestations cranially, they have cranial suture diastasis, large anterior fontanella, craniotabes, frontal bossing, deformities of the skull, skeletal system, thickening of the costochondral junctions, thickening of the joints such as hands, knees, and wrist, ankles, indentation of the ribs, and the diaphragmatic insertion that is known as Harrison groove, whereas indentation and another thing is fractures, especially limbs and long bones, rare metaphysis. Other clinical features are respiratory failure, difficulty from weaning off from the ventilator, hypotonia, and pain while handling due to fractures. Ribs with undermineralization, softening, and fractures can lead to respiratory distress, atelectasis, and pneumonia also. Long-term effects like delayed dental maturation and reduced bone height and bone mineral density will progress into the adulthood. So what are the biochemical markers we'll see in case of osteopenia or prematurity? So we'll see one factor and his significance and some comments on them. Serum calcium. It's a poor biochemical marker because in pathophysiology slide I have explained now, means calcium can be normal because parathyroid hormone causes bone resorption and blood levels in the calcium will be remains normal. So there is no correlation with the X-ray findings or DEXA, means the dual energy X-ray absorption. Serum phosphorate is a moderate indicator, less than 3.5 milligram per deciliter in first 2 weeks of 1 to 2 weeks of life, and less than 5.6 is strongly associated with radiological evidence of metabolic bone disease. Another thing is serum alkaline phosphatase. It is a moderate marker. If serum alkaline phosphate is more than 900 international units per liter, combined with the phosphate of less than 5.6 milligram per deciliter, it will have a 100% sensitivity and 75% specificity. So serum alkaline phosphatase plus phosphorus will give 100% sensitivity and 75% specificity. Parathyroid hormone, it is also an earliest indicator. Increased parathyroid hormone levels and levels more than 180 with phosphorus less than 4.6 combinedly will have a 100% sensitivity and 94% specificity. So in cases of resistant rickets, much better to do the parathyroid hormone levels after maximizing the optimizing the calcium and phosphorus nutrition in the diet. Also, if the baby is not improving, we should do the second line investigations like vitamin D and parathyroid hormone. Tubular reabsorption of phosphate, also known as TRP, it is an indicator of phosphate reabsorption. If tubular reabsorption of phosphorus is more than 95%, it indicates that we are giving less phosphorus for the baby. Normally, it is 75 to 80%. Vitamin D, mostly in first line, we won't do any vitamin D levels in the baby, but if the baby is resistant and not improving with the optimal doses of calcium phosphorus, we will see the vitamin D levels. Mostly it should be more than 30. If less than 20, it indicates a deficiency. Few points regarding the alkaline phosphatase is a marker of osteoblastic bone formation. In preterm babies, alkaline phosphatase will be elevated. Normally also, but from 4 to 6 weeks of age. So AAP Committee of Nutrition recommendation recommends ALP and serum phosphorate concentration to be measured at 4 to 6 weeks after birth in BLBW infants and bi-weekly thereafter. Concentration usually peaks to 400 to 800 also, and then decreases in BLBW babies who don't have any features of metabolic bone disease, and is often but not invariably correlates with the disease severity. Normal neonatal range of ALP is much higher than in adults. Values of 400 to 600 are common in VLBW infants with no evidence of osteopenia. Hepatobiliary disease also elevates the ALP level. Then we should look for other parameters to diagnose the osteopenia of prematurity. One entity known as transient hyperphosphatasemia of infancy is there. In this, there will be solitary elevation of the alkaline phosphatase level. In the absence of any bone abnormality or liver disease, this elevation can rise up to more than or equal to 2000 also, and it can persist for several months. But it is not associated with any pathology, and the etiology is unknown. Another thing is tubular phosphorus reabsorption, also known as TRP. The normal range is 75 to 90, and above 95% is significant marker of insufficient phosphate supplementation. It is calculated with the formula 1 minus urinary phosphorus by urinary creatinine into serum creatinine by serum phosphorus into 100. And other some tests are urinary calcium or phosphate to creatinine ratio may be useful markers, but they are highly dependent on the dietary intake, and they are affected by the diuretics or methylxanthine use, and then depends upon the renal function also. So most commonly we won't do them. So we have seen some biochemical markers. Now we will see how to diagnose the metabolic bone disease. So serum phosphorus and alkaline phosphatase levels. If serum phosphorus is less than 5.6 milligram per deciliter and alkaline phosphatase is more than 900 international units per liter, it will have a 70% sensitivity, 100% sensitivity and 70% specificity. Serum parathyroid hormone, if it is more than 100 picogram per ml, it is suggestive of metabolic bone disease. More than 180 correlates, will also have higher specificity. Tubular reabsorption of phosphate more than 95% with low or normal PTH suggests a phosphate deficiency. And we'll, after biochemical markers, we'll do the X-ray. X-rays, in X-ray, the radiological features evident only after 20 to 40% of the bone is demineralized only. We'll see the features on the X-ray. We have a score in X-rays grade 1, 2, 3. I will tell in the subsequent slides. It's known as WHO score. Another thing is dual energy X-ray So, here we will see the relationship between the parathyroid hormone and tubular reabsorption of the phosphate. So we can interpret it either it can be due to calcium or phosphate deficiency. It will help us to treat the baby. So if parathyroid hormone is high and tubular reabsorption of phosphate is low, so here what we can understand is parathyroid hormone is high, but tubular reabsorption of phosphorus is not there. So phosphate is normal. So it's a calcium deficiency. So we should supplement the baby either with calcium, and if it's not responding, we should do the vitamin D levels, and we can add the vitamin D also mega doses. If the parathyroid hormone is low or normal, if the parathyroid hormone is low or normal with high tubular reabsorption of phosphate, what it means there is a loss of there is low phosphorus intake, so the tubular reabsorption of the phosphate is high. So we can suspect the phosphate deficiency. So here we should supplement the baby with phosphorus, but we should see we are giving optimal doses of calcium and phosphorus in the ratio of 1.7 or 1.5 is to 1. One minute. Next, imaging for the metabolic bone disease, measurement of the bone cortical thickness and visual inspection of the proximal part of the humerus and chest radiograph is a common screen for bone disease. However, the appearance of osteopenia may not be appreciated on the brain film until 20% to 40% decrease in mineralization is reduced. Another is, as we have discussed, dual X-ray absorptiometry. Another is longitudinal quantitative ultrasound measurement of the speed of sound in the long bones combined with the measurement of the serum bone markers is a promising assessment tool. Here goes the Q score. In this, we will see the radiographic findings and we will grade it. Grade 1 is presence of the bone retraction. This is the normal X-ray of the baby. Here it is a grade 1, grade 2, grade 3. In grade 1, there will be loss of white line in the metaphysis. You are seeing, I think. So here the white line in the metaphysis is lost and there is a bone retraction with decreased cortical thickness. We have and in grade 2, there will be the metaphyseal changes such as metaphyseal cupping, fraying, and subperiosteal bone formation will also be there. And grade 3, there will be fractures. Management of the bone health in preterm infants is focused on preventing the rickets. So providing the adequate calcium and phosphorus intake to promote the normal growth. Vitamin D supplementation will have a minor role. Laboratory monitoring to assess the bone health with the goal to detect and correct any mineral metabolism before the infant develops the radiographic findings. And if the baby develops rickets, provision of the supplement calcium and phosphorus to repair the bone mineralization should be the target of treatment. So this is the from the AIMS protocol. Target population we screen is gestational is less than 30 weeks. If the gestation age is 30 to 34 with one of the following risk factors such as parenteral nutrition more than 2 weeks, use of bone active medications for more than 2 weeks, and cholestasis. These all population we will screen at 4 weeks, but we can screen earlier if they are on continuous TPN since birth. If it is normal, we will monitor every 2 weekly until discharge or 40 weeks of PMA. If abnormal, that is ALP more than 900 and phosphate less than 5.6, we will maximize the supplements calcium, phosphorus, vitamin D as tolerated, and will consider stopping the bone active medications if possible, and we will repeat the scan after 2 weeks. If there is no improvement in the repeat screen also, we will order an X-ray to look for any drastic changes, and will do the parathyroid hormone and 25 hydroxyvitamin D levels. If parathyroid hormone is more than 100 picograms and 25 hydroxyvitamin D3 is low, we will consider adding the vitamin D3 2000 Indonesian units daily plus the maintenance dose of 400 for 3 months with adequate supplementation of the calcium and phosphorus. If the serum PTH is less and 25 hydroxy vitamin D3 is more, we consider adding the phosphate supplementation, and will monitor with calcium, phosphorus, ALP every 2 weekly, and we stop monitoring once ALP is less than 500 to 600 and phosphate is more than 4. This is another algorithm. In primary screening, will start at 4 to 6 weeks. Earlier, in some cases, we'll see serum calcium, phosphorus, and ALP. If they are diagnostic of osteopenia prematurity, then we will send the secondary screening such as parathyroid hormone, tubular reabsorption of phosphate, vitamin D, calcium creatinine ratio mostly won't send, and X-ray as needed. If there is elevated PTH and low phosphate, low tubular reabsorption of phosphate, then we will consider either calcium or vitamin D deficiency and we will treat accordingly. If there is normal or low PTH and low serum phosphate with tubular reabsorption of phosphate, consider phosphate deficiency and we will supplement with phosphate and vitamin D if vitamin D level is low. So we'll cover some aspects of management now. First, in case of total parenteral nutrition, hypophosphatemia occurs in 60% of preterms receiving the parenteral nutrition. The cause of this is low absolute intake of phosphate, and high calcium to phosphate ratio can be an attributable factor. It is important that calcium should never be given without phosphate or phosphate without calcium for more than a day or two, because this can quickly lead to hyper or hypocalcemia, and also because bone mineralization depends concurrent availability of both calcium and phosphate. Initial targets in TPN are calcium, elemental calcium of 65 to 100 milligram per kg per day, and phosphorus 50 to 80 milligram per kg per day. In the studies, it has been proven that when we are increasing the calcium intake from 45 to 75 milligram per kg per day and phosphates from 26.5 to 44 milligram per kg per day, there will be improved bone strength. It is measured by ultrasound speed of sound. Further increase to 88 and phosphorus to 80 will also have improved the bone mineralization compared with the lower parenteral intakes, that is 65 and 60 milligram per kg per day respectively. Calcium phosphorus ratio is very important. While we are doing the nutritional audit also, we should focus on this. The optimal ratio is 1.7:1 or 1.3:1. This is in milligrams, but this is molar ratio as recommended by the American Society of Parenteral Nutrition. In randomized control trial, in a ratio of 1.7:1 was associated with improved calcium and phosphorus retention compared to the ratios of 1.3:1 or 2:1. The phosphate requirement and optimal calcium phosphorus ratio also depends upon the amino acid intake, and this was taken from a study which found that hypophosphatemia and hypercalcemia will more likely if amino acids were initiated early without sufficient phosphorus supplementation. Factors that reduce the risk of precipitation in TPN include lower pH. Addition of cysteine to the parenteral nutrition lowers the pH and increases the calcium and phosphate absorption. Higher concentration of the amino acids leading to lower pH. Subsequently, use of monobasic phosphate salt and use of calcium gluconate compared to the calcium chloride. But most of the units will use calcium gluconate only. Higher glucose concentration, prevention of excessive warming of the solution, and using PN less than 24 hours after it has been formulated. This is the treatment of metabolic bone disease in the prematurity, how much calcium, phosphorus, and vitamin D levels we should give. In parenteral nutrition, 75 to 100 mg per kg per day of calcium, 50 to 80 milligram per kg of phosphorus, and 200 to 1000 internations per day of vitamin D. In enteral nutrition, 150 to 220 of calcium, 75 to 140 of phosphorus, and 200 to 1000 of vitamin D we should give. In case of diabetic, 20 to 80 is the range of calcium, phosphate 10 to 50 mg per kg per day, vitamin D 200 to 1000. Now we'll come to enteral feeding. Calcium and phosphorus requirements as per American Academy of Pediatrics are calcium 150 to 220, phosphorus 75 to 140 milligram per kg per day, and ratio should be 1.5 to 1.7 is to 1. Vitamin D 400 international units, whereas Esfagan recommends vitamin D of 400 to 700 international units per kg. This is not international units per day, it is international units per kg per day. Calcium 120 to 200 and phosphorus 66 to 110 milligram per kg per day. These guidelines, why there is broad range for vitamin D is, these guidelines were designed to achieve serum concentration considered sufficient in older infants and children, but they do not recommend routine laboratory testing. Variation in these recommendations reflects that uncertainty about the role of vitamin D for intestinal absorption of the calcium, especially in the preterm babies. In particular, in preterm infants, during the first month of life, calcium absorption appears to be primarily a passive process via paracellular route and is not a vitamin D dependent based on the limited data. Next important aspect in management is fortification of the feeds. For all infants with birth weight less than 1500 grams, we recommend fortification to improve the calcium and phosphorus intake. For babies between 1500 to 2000 also, we'll add fortification, but primarily it for the growth aspect. Routine practice of fortifying the feeds in preterm infants reported rates of rickets in BLBW range from 30 to 50%. But in contrast, the reported rates of rickets among BLBW infants managed with fortified feeds in the modern era are subsequently lower, 10 to 15%. There is reduction from 30 to 10 to 15% by fortification. So these are the various compositions of the calcium phosphorus and its ratio and vitamin D levels in the Calmax P syrup, HMF, that is human milk fortifier, bovine one, and MMF, mother milk fortifier. Another is human milk, how much the calcium, it's 26 milligram per deciliter in 100 ml, and phosphorus is 13 milligrams. HMF plus human milk of 100 ml will give 89.2 and 44.6 of phosphorus, and MMF plus human milk 100 ml will contain 36 mg of calcium and 20 mg of phosphorus. Another aspect of improving the bone capacity is biophysical stimulation. It has been proposed that lack of physical activity contributes to poor bone health in preterm babies. Therapy typically consists of passive range of motion and joint compression exercises performed for 5 to 15 minutes daily. So what is physical stimulation? The duration of the therapy increases progressively up to 15 minutes, turning the baby right or left laterally position. It should be performed during the awake period, that is at least 30 minutes after eating, and we should not disturb the preterm baby sleep. 10 repetitions of each passive movement should be performed at the joint level of the hand, elbow, shoulder, knee and hip. The passive movement sequence is performed slowly from the cranium to the caudal direction. The indicated motion rate is 6 movements per minute. The following sequence is recommended. First, we'll do the right hand, then the left hand, then right foot, left foot, and finally simultaneous movement of the two legs. And total duration of intervention will be the 15 minutes, and at least 5 times per week we should do. So take-home points are metabolic bone disease is the disease of very low birth weight babies, and stopping of the calcipinic and phosphopenic drugs as early as possible is the most important intervention to prevent osteopenia of prematurity. Screening should start from 2 to 3 weeks of age as symptoms appear late. Prevention is by adding the fortifier, preterm formula, using preterm formula, and maintaining the calcium phosphorus ratio in 1.7 to 1.5:1 is most important, and maintaining the vitamin D levels above 30 nanomoles per liter, and never give phosphorus alone, optimized based on the bone profile values. Thank you.